Thank you very much, Brian, and thank you for the opportunity to speak. I know I stand between you and lunch, and I have a talk that is on a topic that's quite technical, so I'm going to try to keep it as minimize the technicality and try to speak to how the programs are generally working, what is important to know as an emergency physician who's going into academic leadership, and sort of roles that we can do around payment reform. So I have some funding from the Center for Medicare and Medicaid Innovation, leading a support and alignment network from ASAP. It has something to do with this, which I will show you. Besides that, no related funding. So our objectives are to review the value framework in healthcare, describe the key elements of MACRA for academic emergency medicine, what's the law, how are you going to participate, describe organized emergency medicine's response to MACRA. I'll briefly talk about ASAP's clinical emergency data registry and ASAP's proposed advanced alternative payment model. So the biggest challenge in this, giving a talk in this area, is that it is alphabet soup. Like many government programs, everything is a 3, 4, 5-word program, lots of acronyms. I will try to spell these all out. I think it's important to think about these programs, what we're going to be calling MACRA and MIPS in the APM program, in light of a movement around payment reform that's really gone on for 15 or 20 years. So the search has been to try to pay for value in healthcare. And it's easy to draw this as an equation. It's much harder to actually define and measure it and then create a payment system that truly rewards value. But the idea is value is quality over cost. So increase quality, you increase value. Decrease cost and hold quality steady, you increase value. This has gotten more refined. Now we're thinking about outcomes and patient experiences and thinking about the different types of costs. So back in about 2014, 2015, when Don Berwick was at HHS, they really tried to steer the ship to looking long-term to change the way that Medicare paid for care to align with value. And the thought was that fee-for-service, basically just giving physicians, hospitals a payment for each thing we did not align well with population health, which was the goal that Berwick really brought to CMS. And so they put together this model that was to try to switch payments from what was largely fee-for-service. You can see in 2011, either fee-for-service or fee-for-service linked to quality just meant that there were quality measures associated with those payments. It didn't mean there was much money at risk, to where they wanted to be this year, which was half of Medicare payments through what are called alternative payment models, which I'll talk about a little bit more, but there are alternatives to fee-for-service. This was partly put into parts of the Affordable Care Act and then was reinforced with the law MACRA, which we'll talk about. So the Affordable Care Act really spread accountable care organizations. These are structures that have physician leadership, and they bring together different parts of the healthcare system to collaborate on care with a common aim of improving health. There are multiple different business models of ACOs. The goal is to have aligned financial incentives with shared savings if the entity is able to improve health and decrease cost. So these are just a couple of different Medicare ACO models. And the point of the graph is to show that for the population that is captured within an ACO, most of the healthcare spending is not directly to the ACO, but the point of the ACO is to say, you know, hospital, doctors group, affiliated, other services that are part of the ACO. If you manage health, you will actually be able to affect the overall healthcare spending in addition to improving the patient's quality of care. So for this talk, we're really going to focus on provider payments, doctor, nurse practitioner, PA payments. It's important to know that the payment structure that we have in the country really flows from federal laws that evolved over a number of years in terms of government payment. So on the left, you have how hospital inpatient stays get paid for. That's Medicare Part A. Those payments are generally in the tens, maybe up to hundreds of thousands of dollars. For emergency department visits, there are two bills. In the middle is the hospital facility bill, what the hospital charges for the ED visit, and that's part of Medicare Part B. That tends to be in the high hundreds or thousands of dollars. And then the provider bills, which are E&M codes 1 through 5, and those tend to be in the tens to hundreds of dollars. So we're going to do a couple of polls. So if you have your phone, you can text to code 22333. And the question is, how does your EM faculty group bill Medicare? What is the structure in relationship to the tax ID? And there are 4 choices. I don't know is at the bottom. You would text that number. The 3 ways you could do it are each emergency medicine faculty member has their own tax ID and submits bills to Medicare. Maybe it's done by staff. 1 large tax ID for the group, or that your emergency department, emergency faculty is part of a larger multi-specialty group that all has a tax ID number. I can say at Brigham and Women's, we're at the bottom of the options, which is we have a large multi-specialty group that was built up over 25 years or so, and there is 1 tax ID number that includes emergency medicine, anesthesia, et cetera, and all of our bills go into Medicare under that tax ID. So I put this here because this is an important piece to understand about how you bill Medicare and how you're going to participate in these programs. And so if this is something that you're going to learn more about, it's worth spending a couple of minutes with whoever the business or finance manager for your group is and learning a little bit about that. But it looks like a split between multi-specialty group and larger group, and some people who are not exactly sure. The top one's pretty unusual nowadays. It's just too administratively complex. In some small practices, that may be the case, but it's not typically the case. So provider value-based payment, MACRA, MIPS, and APMs. I could show any number of graphs about healthcare finance, but the main thing to know about all of this is that whatever administration comes, whatever exact law is passed, there's a fundamental reality that's going to continue pushing this all in the same direction, which is that there's no new money for healthcare. The technological costs of healthcare are going up, the population is aging, and so the cost of healthcare is going to rise faster than our society is willing to put more money in. And so for the rest of our careers, we are going to be in a constant battle about resources for healthcare. And it's a real question because in our cities and towns, those resources directly compete against other social services, whether it's kids' education, social services for homelessness, food, tax cuts, whatever individuals value. And so on the physician side, back in the late 90s, Congress passed something called the Sustainable Growth Rate. And what this graph shows is that the sustainable growth rate wasn't actually sustainable. It basically updated every year, and since the cost of healthcare went up more than the economy grew, Congress, by this law, was supposed to cut payments to doctors. But that was politically unpopular, and so each 6 months or a year, they would update the law and basically kick the can down the road to the point where in the late 2000s, if they had let the law keep going, there would have been a 30 or 40 or 50% cut to physicians at one point, and that was clearly politically not acceptable. So in 2015, Congress passed MACRA as part of a budget reauthorization, and there was strong bipartisan support. That's another reason that this is unlikely to change. And it did 2 things. It repealed that sustainable growth rate, and it created something called the Quality Payment Program, which is what we're going to mostly talk about. It really had 2 goals. One was to create a realistic vision of how much it was going to cost Medicare to pay for physician and other provider services. You saw from that last graph that essentially there was a fiction in the federal budget that each year it was going to cost a lot less than it actually we knew it was going to cost. And so this allowed a whole reset on that. And it also was set up to accelerate the shift away from traditional fee-for-service payments. So what is the quality payment program? It's basically the way in which providers, physicians, PAs, NPs, are paid by Medicare. And there are two tracks that you can choose or be part of in the way you're going to get paid. The first is called the Merit-Based Incentive Payment System, acronym MIPS, and that's for providers who are largely fee-for-service. And it's, we'll talk about it in more detail, but basically it's fee-for-service plus an adjustment. The other path is to be engaged in an advanced alternative payment model where a significant percentage of the payments you get from Medicare are not fee-for-service, and we'll talk more about that in a moment. So advanced APM, the Medicare definition is that you have to have quality measures as part of it. You have to use an electronic health record that's certified, and then you have to bear more than what is called nominal risk. Fee-for-service is no risk. I go and see 10 patients, I get paid for seeing those 10 patients. Risk means that there is some amount of that reimbursement that is at stake that I could lose if I don't either meet quality metrics or do other things, for example, keep total costs down. And so for 2018, the number is 8% of the total payments from Medicare need to be in the, whatever ACO or APM you're in. That's actually a lot of money. Most of these ACOs, even on the commercial side, are having 2, 3, 4, 5% of the total payments are at risk. To say that 10 cents on every dollar is at risk is a very different way of operating a business than most of our departments have operated, and puts a hospital or physician group at risk of having a significant shortfall if you don't make that. So you have to change your business model. So there are a number of Medicare ACOs. They're all listed here. The ones that are bolded are the ones that emergency physicians might be part of if you're in Vermont. If you're part of a next generation ACO, Partners Healthcare is one of these. There are about 15 in the country. And then a number of, the largest group is the Medicare and Shared Savings Programs. And so if your group is in a multi-specialty group aligned with a hospital in one of these systems, you will be an advanced APM. But for most emergency physicians, that will not be the case. Most of us will be in MIPS. And so the physician's pay follows a traditional fee-for-service structure, but CMS then adjusts the payment based on how we score in 4 categories: quality of care, advancing care information, a wonderful acronym they made up, which really is, do you use a certified electronic health record? It's what used to be meaningful use. Cost, which I'll talk more about, and improvement activities, which are typical QI sorts of things that we're all familiar with. And so based on their performance on these metrics, Medicare adjusts the participant's score and then adjusts payments. There's a 2-year lag. So your performance in calendar year 2018 affects your payment for 2020. And that's one of the reasons why it's important to get ahead of this stuff, because if you sort of say, well, I'm going to wait till the payments go up, the risk goes up, you're potentially going to have a 1.5 to 2-year lag until you could do anything. So how will MACRA affect you? This is about as simple as we can make it, still too complex, but basically the question is, are you in an alternative payment model with Medicare? If so, is that alternative payment model eligible? That's the whole left side, and we'll go back to that in a minute. But otherwise, you're in MIPS. And so we will talk more about MIPS. So the law was passed in 2015, and in 2017, they updated the law a little bit and did 2 things. They made it the adoption rate a little bit slower, and they also slowed down the payment updates. And so what this graph shows is the cumulative updates that are happening outside of the incentive program since the law was passed in 2015. And inflation is low currently, but it's still 1 or 2%. And what you can see is that over about 5 years, the total growth of Medicare for physicians is less than 3%. So in an inflation-adjusted sense, we are getting cut by Medicare at the baseline rate. And then there are two tracks. On the bigger growth rate is if you're in an advanced alternative payment model. And you can see that you can make a higher bonus if you're in that, and that's one of their incentives to try to get organizations and providers to join advanced APMs. And then the merit-based incentive system has baseline adjustments, and then there's a up or down that will happen. And this is really the up or down. So starting in 2019, which was based on last year's performance, because it started last year, your Medicare physician payments can be adjusted up or down 4%. So that's an 8% change. Within 4 years, when we're in 2022, it'll be up or down 9%. So how big a deal is that? We'll get there. Well, I'll show that first. So it's real money. It's not all of your money by any chance. Nationally, this applies to Medicare Part B who are not in Medicare Advantage plans, where seniors go and can get their insurance through United or one of the other companies that offers a commercial option. And so nationally, Medicare visits account for about 18% of ED visits across the country. Depending on where you practice, you may be as low as 5 or 10%. You may be as high as 30 or 35%. And you can see that for an 80,000 visit ED, by 2022, that will be $215,000 at risk. That would go up if you have a higher proportion of Medicare than about 20%. So the next poll question is, how is your group participating in MACRA for this year? It started last year. It was the transition year. This year it's fully running. And so the options are MIPS, an advanced APM, not participating, or unsure. Medicare has done some analysis, and they have published nationally that about 75% of providers are going to be in MIPS at the beginning. And ASAP has done some analysis, and the proportion's even higher for emergency physicians because we are more likely to be in groups that are not really closely aligned with hospitals outside of academics. So it looks like of people who know, a few more in the MIPS pathway, some in the APM pathway. But this is something else that you can ask your business manager, and then usually if you're affiliated with a multi-specialty group, there are people in the multi-specialty group who are leading this. So how does MIPS work? They've devised these 4 categories, and over the next 5 years, it transitions with different amounts of weight on the different categories. For this year, for 2018, half of the weight is quality, 10% of the weight is cost, 15% is improvement activities, 25% is advancing care information, which is the electronic health record. And that is, emergency medicine is exempt from that for right now, so essentially you inflate the other 3 groups. How can you participate? In theory, you can participate as an individual. We had very few folks here, and nationally in academic emergency medicine, that would be quite rare. You can participate as a group, and it's really as your tax ID number. And that may be different than what your academic group is, because it depends how the business is organized. It might be organized by site. You might have multiple tax IDs for a number of different reasons. And they've started something new called a virtual group, which actually makes sense for emergency medicine, but probably few emergency physicians will end up doing that. We'll talk about that briefly in a minute. So the other option is facility-based measurement. So when they created this program, they were thinking about the model of office-based physicians, which is most physicians, but emergency medicine, anesthesiology, pathology, a few other specialties that are largely hospital-based, have some challenges with particularly the cost side of things. And so a new way you can choose to participate in MIPS is by affiliating yourself with whatever facility you practice with. The challenge about this is that the quality measures that you will get measured on are the hospital-based quality measures that we're all familiar with. So right now, for emergency medicine, that is sepsis, ED, length of stay, and there's a CT measure for stroke, and there are a couple others. But they tend to be things that emergency physicians don't think are great measures of our practice. And so I do not think a lot of emergency departments and physicians are going to choose this option. So this just illustrates the 2-year time lag again. In a calendar year, there's a performance period. It's actually for these activities, it's not the full 12 months. I'm not going to go into all the detail, but for some of them, you can have a 3-month period of performance. You submit your data. It has to be submitted by March 31st of the next year, and then the adjustment happens a full year after that submission for the payments of that year. This is all done on a calendar year basis. So the other thing about MIPS, and this is why it holds costs steady for the government, is that it is revenue neutral. The bonuses that are given out to high performers come by giving cuts to people who are low performers. And that is a change in Medicare payment, and it's another reason to try to get ahead of this. So for 2017, the first year, the way it worked is that you can see on the left, and do we have a pointer? You can see on the left that if you didn't participate, basically you had 0 points, you got a negative payment adjustment of negative 4%. So you wanted to do whatever you could. Thanks. Okay. No, that shut it off. There we go. It's green. That's why. So in the first year, if you didn't participate, meaning you did nothing, none of those 4 activities, you got a negative 4%. So you really wanted to avoid that. And in general, you want to avoid non-participation because you will get a negative 5%, and then it'll go up to the negative 9%. For the first year, the threshold for participation was 3 points. That basically meant you had to submit 1 quality measure, do a couple of basic improvement activities. You had to just do very minimal participation. Each year over the next couple of years, they're raising that threshold. So you can see for this year, the threshold is 15 points. And so if you're less than 15 points, you will be considered for a negative payment adjustment. If you're less than 3.7 points, you'll be considered a non-participant, and you'll get a full negative 5%. And so the question is, how can I achieve those 15 points? And the 4 bullets at the bottom explain that. You could do all of the improvement activities required. You could submit 1 quality measure and do the advancing care information, or you could submit 6 quality measures. So for emergency medicine, it's basically doing all of the improvement activities or doing 6 quality measures will get you no negative adjustment. If you do more than that, you will get something above 15 up towards 100, and you can see that there will be a positive adjustment. Depending on how many physicians and groups get that positive adjustment, it will determine the bonus, because the bonus pool is based on how many people have the negative. If a lot fewer people get a positive, the bonuses could be quite large for the first couple of years until many people are participating in this. So there are multiple methods to participate in terms of getting MIPS data to CMS. The quality data can be submitted a number of different ways. I'm going to talk about CEDR, which is one method. The cost data is calculated by Medicare. There's nothing you have to submit. I'll talk about that. It's very confusing. Advancing care information is basically an attestation, so that's simple. It's the group attesting that we use a level X certified electronic health record. The improvement activities can also be attestations, or they can be, you can get credit for that if you're using a clinical data registry, which I'll talk about a little bit more in the quality data. But basically, by March 31st of next year, the group needs to submit or know how they're giving data for quality or improvement activities to get those points. So next quiz is, how is your group submitting MIPS quality data? It looked like of the people who knew that what they were going to be participating in, about half were going to be in MIPS. So if you know your group's going to be in MIPS, are you using ACEP's registry? Are you using another registry? CEP has a registry. Some large academic medical centers have registries. We have a registry that was developed by one of our sister hospitals. Is there another mechanism you're using, or are you unsure? And so a qualified clinical data registry is different than, I think, how most of us think of registries as academicians. Most of us think of registries from the research perspective, and also maybe the trauma registry, the Society for Thoracic Surgery residency, where you start with a cohort of patients for a specific question and gather a bunch of information, often lots of detailed chart review. Qualified clinical data registries are registries in the sense they do have that population of patients, but they don't necessarily have chart review or the level of detail that you would have in the trauma registry. They just have to have data collected that meets the quality measures that have been approved by CMS in a standard format so that you can calculate performance and submit it directly to CMS in an electronic format. Medicare used to calculate all of the stuff itself. They want to get out of the business of calculating it. They want the clinical data registry to calculate it and send them the information. So the reporting structure will depend on the business structure. Multi-specialty groups with one TIN are going to report, depending on the history, maybe not report a lot of emergency medicine measures. There are still, as of right now, ways to report, for example, on primary care or cardiology measures and get credit for the whole group, which is how our academic medical center is doing it. If you're a single specialty group, you need to participate in one of the EM registries. So I'm going to talk for a moment about CEDR. That's ACEP's Clinical Emergency Data Registry. For the last 15 or 20 years, ACEP had, I think, 4 different task forces, all of which recommended putting together a registry. But there was never a business case to do it. And so the first 3 task forces were ignored, and then the 4th task force came about right before MACRA passed, and all of a sudden there was a business case to have a registry, because without a qualified clinical data registry, most emergency physicians will not have a way to submit data to MIPS. So it's designed to measure healthcare quality and outcomes. It's the first and only emergency medicine specialty registry at a national level. There are some others that are being developed. They're not quite as big. As of now, it has a few more than 43, but it has in the 40 number of quality measures. It has length of stay measures, it has sepsis measures that were developed by ACEP. It has some choosing wisely and appropriateness measures, tobacco screening, and some other miscellaneous measures. There's a tension. We needed to develop measures relatively rapidly, and we needed to develop measures that were meaningful. At the same time, they needed to be things that could be collected ideally from claims data, and if not, from an EHR feed. And I'll go to some of the lessons learned in a minute. The good news for, I think, the specialty is that CEDR is moving forward. As of this year, there are over 1,000 emergency departments that are engaged. They're working with many different EHR systems, and so this is moving forward. But there are definitely challenges, and if you've done work with CEDR, there are 2 main buckets of challenges. Those are around measure development, coming up with measures that are meaningful to clinicians and for which there's a gap is hard to balance with things that are easily measured. So it's easy to measure if we gave aspirin for MI, but that gap is gone. So we need to find things where there's a gap, but often those have lots of exclusions, which are difficult to gather. If you're not doing chart review, you have to pull them all out as electronic health record fields. It takes a lot of work to align different electronic health records. The second piece is acceptability to emergency medicine providers. Measures that would be very acceptable in your own emergency department for quality improvement because you know you're only doing it 50% of the time and it's good care. If all of a sudden you're competing against all of the other emergency docs and groups in the registry, and if you do worse than average, you're going to lose money, all of a sudden, most people want a measure that they feel like they can meet. So that creates its own challenge. There are also significant implementation challenges, as opposed to something like thoracic surgery, where they have a relatively small patient population, high reimbursement. They've been doing this for a long time. We have this very large patient population, diverse set of clinical conditions, lots of different electronic health records, and in particular, most of us are tied to hospital electronic health records, and so much of the implementation work is getting the hospital to agree to support the IT piece of this. But there is actually a registry. There's a dashboard. If you are participating, you can get a view of the different measures that you choose to submit, and that's sort of what it looks like. MIPS, so that's one category, quality. That's 50% of the points. Improvement activities, second category. This is like typical quality improvement stuff. Medicare now has over 40 activities. They range from using the PDMP every time you prescribe an opiate to sharing performance data with your group. So there are lots of ways you could do this internally. If you already have a robust QI program, you probably are doing things that meet this and you can attest to them. For those emergency departments that don't have that, so lots of community, smaller EDs, ASAP has developed something called eQual, and that's what I have grant funding for CMMI from. It's a remote national learning collaborative that's working on 4 different topics that are listed here: sepsis, imaging, low-risk chest pain, and now opioids. And it allows emergency departments to do local quality improvement with central guidance, submit some basic data, and Medicare has signed off on this as a verified improvement activity. So that's something that is available. The cost measures. These are very complex, and they're just newly implemented this year. They've been collecting them for 6 or 7 years, and you can actually request the data from Medicare in something called the Quality and Resource Use Report. But it's hard to understand exactly how they apply to emergency medicine. There are 2 measures. One is total cost per capita, and that makes sense if you think about if you're a primary care doc and you have a panel of 3,000 patients, it's the cost to Medicare of those 3,000 patients who you primarily care for. The Medicare spending per beneficiary is defined as the 30 days around a hospitalization, and it's attributed to the provider who has the greatest in-hospital contact with that patient. And so there will be some cases where emergency medicine is that provider, and that is what is likely to come out as our cost measure for right now. As you can imagine, that does not really very well reflect our contribution to cost. So I'll talk about how people are thinking about that. But as of right now, it's only 10%, and so I think there's going to be more input once we know how that looks across groups. So that was MIPS in a nutshell. We're going to talk for a moment about advanced APMs, because this is the other way you can participate in the quality payment program. If your reporting is your own entity, Department of Emergency Medicine, not in a multi-specialty group, ACO, et cetera, there's not currently an emergency medicine APM that you can decide to participate in if you're not already in some other group. Even if you are in some other group, it's not obvious that you automatically will get credit, because the thresholds are that 20% of your Medicare patients, a quarter of your Medicare charges, have to be covered by that alternative payment model. And that's why some of the ACOs that are out there from Medicare don't actually count. And if you think about emergency medicine, we've got such a diverse group of conditions that it would be, if you were doing an APM around oncology, if you were part of the oncology APM, that's not going to account for 20% of your patients. So most academic departments will be doing MIPS if you're not in one of the advanced ACOs. So ASAP has been working on this. They had a task force for the last 3 years that developed an advanced APM that's been submitted to this government organization called the Payment Task Force Advisory Committee for review, and there's a thought that it will likely get approved. And the goal of this is to allow emergency medicine groups to participate in the advanced APM model. And this is the basic vision of the model. And you've got to think about this as an alternative to our typical fee-for-service payment. And so the model initiation is an emergency department visit. And then the theory behind this is that our biggest impact on population health and on cost is whether or not we admit people, and then our coordination immediately after with high-risk patients, for example, older adults who fall. And so the model has measures such as return visits to the ED, and how often patients are hospitalized, and also outcomes of death. And so there are a whole series of measures that can be calculated. For example, what is the admission rate for patients with syncope from your emergency department group? And it basically tries to align with the current CMS model, but in a way that an emergency medicine only group could calculate many of these things. And the supporting evidence is the evidence on variation around admissions and outcomes. And so this is one of the figures from the submission. And we know there's wide variation in the rates of admission after ED visits for many conditions for which we have outpatient pathways. This is syncope. It shows a series of EDs in Medicare data, and this is the variation in admission rate, even after adjusting for age and other comorbidities. And this is the post-discharge event rate, and this is patients who came back and were readmitted, had a fall, some other post-discharge events. And what the point is that there's not a direct correlation with admitting more patients and fewer events. And so you can have high-quality care and admit fewer patients, and that is why there's a potential cost savings for Medicare and the model of how there will be cost savings for emergency medicine if you enter this model. So as academic emergency medicine leaders, what can you do? I think thinking forward, this is definitely the direction things are going. It's hard to know exactly what model is going to evolve, if that ACEP model is going to be approved as is, which measures will be developed, which of the ACOs will expand. But making sure that your emergency department is at the center of hospital initiatives that are talking about cost and quality, particularly around admission to the hospital and close coordination after ED discharges, because those are two things that we can have a lot of impact on that affect health and cost. Think about your business plan. How are you going to survive in a world where ED volume may be flat or decreasing? We all like to scoff at the idea that better primary care will reduce ED visits. And the reason we can scoff at it is because most of the time the primary care is actually not that much better. But the systems that have actually figured this out, whether it's Kaiser or other places, really can reduce ED visits. And we all know there are a significant number of patients in our emergency department who, if there was a lower cost alternative that was open 24/7, 365, might go there instead. And then you have to think about how you're going to optimize shared service agreements, meaning business agreements with the hospital, with the payer, to try to incorporate aligned metrics. Because even though we can do great work to reduce hospitalization, to improve care coordination, for example, with frequent ED visitors, the fee-for-service model doesn't pay us to do that. If you have a doc who's creating care plans for your frequent visitors, they're helping the system. They may help the entity, but there's no payment coming to emergency medicine to do that. So in summary, payers are shifting away from straight fee-for-service as a way to control costs and improve value. This isn't going to stop because there's no new money. You can think about it as depressing, but I think it's better just to think that's the world we live in, and we have this great opportunity to help improve health and manage cost. Medicare is shifting to value. We went over MACRA, and there are the two options, MIPS and APMs. Academic emergency physicians will participate in MACRA mostly through MIPS, some through a health system or hospital, and currently most won't do it just through a physician group. And I would make the point that I think we're extremely well positioned to lead on value and population health, but we need to figure out a way to do this in a way that we can get paid for doing that work. Happy to take any questions. And I'll make sure that the slides are available. If you want to learn more about this, Medicare has a really good website. They contracted out on this one, and there's a fabulous website, which is just QPP. If you Google like CMS QPP, it comes up, and it is unlike any other Medicare website. It actually is very user-friendly and has slide decks and answers lots of questions. Thanks.
Thank you, Jay. Question.
Hi, Jay. Haven't seen you in years since we were at Brown, but hello.
Hi.
But thank you for the presentation on this. The question I have is one of the challenges we face in our organizations is resident training education and helping them understand that the effect, even as they're training, we have to give them the freedom to learn how to order, learn about patient care, yet they're still in some way affecting the providers' metrics in this regard. How do we balance that, educate them on what they need to know, and ensure that they're prepared the best way when they graduate to step into this, because there's no longer that I'm a brand new attending run up, I got time to learn. They got to learn that before they leave residency. So do you have any suggestions on how we best navigate that transition?
I have a couple. I mean, I think it's a real challenge. I don't think it's new to this. There have been measures and other things that we've been held accountable for. I would say, number one, you need to make sure the attendings are educated on this stuff. Most of our attendings don't actually know many don't understand the difference between Part A and Part B of Medicare, know what the breakdown of commercial payment and stuff is. And that's important not so that everyone's an expert, but so that people don't spread misinformation. I hear all sorts of misinformation. For example, the hospital doesn't get paid for readmissions. That is not true. The hospital may get a penalty if you have a higher rate of readmissions, but the misinformation, I think, can lead to patient harm because residents particularly are trying to do the right thing. And if they are told, for example, that readmissions the hospital is not going to get paid for them, they may have a much higher threshold to readmit someone who it's clinically important. So I would say educate your faculty and then include the general pieces in resident education, but this stuff is so detailed and it's going to change. The details are going to change. Don't focus on the details. Focus on the pieces that are clinically relevant. For example, what programs do you have around appropriate imaging? What can you do? Because that's something that is a great thing to work with residents on, and you can link it to quality and value, but you don't have to get into the payment program details.
Okay, more questions.
I was particularly interested by the data you presented around syncope and variation in admission rates. Is that by any chance available on the QPP website or on another website?
It's in the link at the end in the references. It's in ACEP's application to the PTAC. They do this for syncope and AFib, and there's a body of work now that's out around this with variation in admission and not necessarily linking to outcomes. But yes, it's publicly available, and I'm happy to, I can just give it to you after the talk if you want it.
Thank you.
Okay, next.
You mentioned that it's the same pool of money and it's going to be shifted around. So who's going to be the big winner? And the reason I ask that is, like you said, there's a lot of things that we'll have to do as a department that's going to be unfunded. So who do we ask for that money? Because where's it going, basically?
So I think sort of two questions. The first is the MIPS program is a plus-minus system. And so if you're in this, right away the big winners are going to be the groups that got started on this right away and have figured it out. And I can tell you the for-profit and large contracting groups are all over this. And it's not surprising. They've got economies of scale, but they are going to score all of the points. And groups that are doing this in a less organized fashion, we're going to get penalized at the beginning until people figure this out a little bit better. I think the second question is sort of how do you get paid for the other work in terms of population health. I think you have to make a business case to the people in your organization. If you're in a tightly aligned organization with a hospital or a health system, it's easier to do that. You can identify things that they're trying to work on, whether it's reducing short-stay hospital admissions or improving post-discharge outcomes, and then say, we can put this program together for frequent ED users and we can reduce this or that outcome, but we need to fund a program manager, we need these other things. And ideally, you could even get some of the shared savings. It's harder to do if you're in a group that is not closely aligned with the health system, but there are ways to do it. It's all in the contracting.
One last question.
I was struck during your presentation by the fact that the advanced practice models aren't really existent in the emergency medicine space right now. And I was thinking, like, if you're a group that you expect to face a negative penalty, that there would be huge benefits to participating in the advanced practice models, and whether you see like ACOs developing specifically for the purpose of taking advantage of that, so that they can essentially say like, hey, we'll get you out of this whole thing, even though you're taking on risk. Even if you lost all the money that's at risk, you still wouldn't lose as much as it's going to cost you to implement MIPS and pay your penalties when you don't meet the
So I think that's a good observation. Basically, if you stay in MIPS, there's a lot more risk than if you do the APM participation. There are two challenges about the APM piece. The first is you have to get, this year, 20% of your Medicare payments to be in that model and a quarter of your Medicare dollars, and that actually goes up over the next 4 or 5 years to where it's about half of your Medicare patients. So a model like an ACO works, but some of these advanced some of the shared savings programs that focus on a handful of conditions work well for that specialty, but for emergency medicine, they don't work particularly well. And that's why this APM model that ASAP has put together is really important, whether it's that or some other model that deals with acute care, because that's the business that we're in. And you'd have to take abdominal pain, chest pain, 10 complaints to get to 50% of our patients, and that's much more difficult.